So I'm Dr. Liz Gwyther. I work at the University of Cape Town in palliative medicine, and I am also the CEO of the Hospice Palliative Care Alliance in South Africa and the chair of the Worldwide Hospice Palliative Care Alliance.
And I'm Richard Hardy. I'm Professor of Palliative Care and Rehabilitation in the Cicely Saunders Institute at King's College London.
I try to explain that we may be the experts on the illness and the disease, but we don't know the person, and we don't know how this is affecting them, and we don't know what are the worries, the fears, the strengths and the coping skills of our patients. So person-centred care is recognising that the patient is the expert of their own context, and we have to bring the care to them in that context. So that's, to me, what person-centred care is, just listening to the person and trying to understand where they are in their illness and what their preferences and choices for care would be, rather than preferences for treatment.
So thanks very much, Liz. So Richard, if I was a patient and receiving person-centred care, what would I notice about that, do you think? What would be my experience?
What we would hope to achieve is a sense of a culture shift in how clinical care is delivered. So you would hope that the patient and the family would experience care which is more centred on them and their needs, rather than the expectations and the standard procedures of a health system. So you would feel hopefully more of a partner in the decisions that are being made about your care. And also you would feel that the care is more responsive to your needs rather than the existing structures within which they're delivered. So you would hope to feel that you have some sense of agency in the care that you're going to receive, and some sense of choice in what's being delivered, within, of course, the restrictions of resource allocation towards health services. You'd also hope that it's more efficient, that by enabling somebody to be person-centred in their assessment and then their receipt of care, it will enable you to more quickly and easily focus on what matters to you now and your primary needs.
Liz, one of the themes of the asset research is looking at comorbidity, so the complexity of providing care for continuing care for chronic diseases, where it's often not one condition but several or many that people experience. So how is person-centred care relevant in that context?
A patient may be with us for 15 minutes every 2 months, every 6 months, but they're living 24 hours a day with their illness. How do they manage it? So when there are multiple comorbidities, it's to try and tease out for the patient what might be behind this, but they're experiencing symptoms. So that's one of the strengths of palliative care. We look at symptom control and not specifically at disease control, because we're working in partnership with the clinicians who are looking at disease control. So it's really empowering the person to be the expert in their illness and to make sure that they're taking their medication on time and they understand why, because without that understanding, they're going to skip doses. There's going to be resistance to antiretrovirals or TB drugs, and so it really is that business of making sure that we check the person's understanding and that they know that they can ask us any question, that no question. And quite often I've had patients say to me, but I couldn't ask the doctor that, and it sounds so stupid. No question is a stupid question when it's about your illness and your health.
I think what we're trying to initiate is culture shift. So patients, of course, have always been socialised to be passive recipients in care. So there's a shift to patient empowerment to make patients actually feel able to ask that stupid question, to bring into the room the social, psychological, spiritual concerns that they may have, which is part of their disease experience, which they've always been led to believe is not part of their care, is not a holistic care need. So the non-medical issues need to be brought back into the room. Patients need to feel empowered to do that. Because if we want to deliver care that's got any chance of being effective, then you need to understand the patient's social context. So they need to be able to bring that back into the room, but also clinicians have got to feel able to relinquish some of their power and to engage in a partnership. So there's culture shift from patients and staff.
And one of the problems that clinicians have, especially when talking about end-of-life care, is what's going to be the emotional reaction. And sometimes is the patient going to blame me because this is no longer curable or whatever. So clinicians hide behind medical jargon and kind of distance themselves from that engagement with the person. And so having the confidence to recognize that the emotions aren't directed at you and how to best contain the emotions and how to give the person tools to help contain those emotions is also really important. And a lot of people think, oh, but this is going to take so much more time. It actually saves time because you engaging well with the person who then becomes a partner in the care, and the self-care helps the clinical care alongside this. So I think it's critically important, and doctors who engage in this way are quite amazed at how much more effective their care is once they've taken a patient-centred or person-centred approach.
Whole person care may not be probably equivalent to person-centered care. In my view, especially in our setup, we perceive that our actions or our practice in medicine just taken as similar for everybody, and we try to treat every person same way. This means we leave out the individual needs, the personal needs that the patient or a person might require. Probably a person may come with some masses or lesions, but his worry could be about the effect of that lesion on his psyche, on his social activities or social relations, and so on. So for me, I'm not wrong, what I understand by person-centered care is tailoring our interactions, our practice to the specific needs of that person, though the ailments or the needs look similar. In our setup in Ethiopia, I think for many reasons, person-centered care is at a very, very low level, at a rudimentary stage. But I have hope that we have to change this. Traditional healers are part of the community. They know what the community demands, and they are being given a setting where that person lives, and also it respects their culture, their values, and so on. So when I say it looks more person-centered than the modern medical practice in Ethiopia. Yes. And I did a very small survey on our surgical residents. The question is not on the status of whole person care, but how do we teach and how do they learn and practice whole person care? And in this survey, what I found is there are only 2 ways, and we are teaching them in only 2 ways. These are observation. They observe their seniors or other medical staff on how we deal with our patients. The other was trial and error. They try one way of consultation or counseling and so on. If they think it is successful, they continue. If they think it is not, they just drop it. So you can easily understand that there is no really well-organized, explicit way of teaching our surgical residents on whole person care. There are barriers, one being attitude. Attitude of individual instructors, attitude of authorities. So if we don't work on this, it is difficult to bring person-centered care. The other thing, the environment. You know, patients are, for example, being treated in a very big ward, 6-8 of them being there. So you cannot discuss private things. For example, we are constructing a lot of hospitals, a lot of health centers, and so on. You know, if we really do not consider these things, we may build rooms for just physical examination, for dressing, for injections, whatever, but no area for counseling, no area for physical exercise. If you take surgery, there are only few surgeons with a lot of patients. So they are busy. There is no adequate time to discuss with patients. There must be, change in the curriculum, for example, for explicit learning, for reflections, and an instructor may need to explain why he's acting in a certain way for his students, so that we can change the situation rapidly. So the learning method and the environment we work in are the main barriers. I think recently the government launched this compassionate, respectful and caring agenda, and there are so many discussions, forums and also conferences on this. And there are also some champions on this, and there are also evaluation formats for health facilities and the health workforce on this, but I feel that's not enough. We need a lot of other things. So we have to work on the attitude. We have to work on also other, disciplines in the health service, like architects, engineers, to understand this. And when they design facilities and so on, they should have settings in mind and do the necessary arrangements. We need also to develop some guidelines on person-centered care, and we need to have a clear understanding what it is when it comes to the practice. I know there are so many talks about person-centered care, patient-centered care, and so on. I don't think, even including myself, we have a clear understanding of it when it comes to practice.